Yep. It's
Okay,
recording, right?
we're recording the meeting. I don't know if you can see also with me.
We can see you.
And this is Takiwa Manami, who's also involved in Acorn. He's he's chair of the Counseling and Psych program at the University of Massachusetts, Boston.
Hi.
Hi.
Can't see you all, but
So he's here visiting. We're working together. We're actually in North Carolina this week, so we're in the lovely Blue Ridge Mountains of North Carolina.
Sounds nice. What town are you in?
Blowing Rock, North Carolina,
Okay.
which is sitting right on top of the Blue Ridge Mountains. It's the only town that the Blue Ridge Parkway actually goes through the town limits. And we are literally sitting, let me see if I can indulge me,
Yeah.
point out the window there. We are sitting right on top of the Blue Ridge, looking out over the Pisgah National Forest, uninterrupted national forest as far as the eye can see. At night, there are no lights out there. It's all national forest.
Oh, nice.
Yeah.
I was just in Asheville a couple months ago.
My daughter lives in Asheville. Asheville's a happening place, isn't it?
It is. It's hopping.
It is wild.
There was great music in Asheville when we were there. Yeah.
It's a great music scene. It's a great food scene. It's a terrific beer scene. They've got, I think, more breweries per capita than almost any place in the country. And now some of the big ones, Sierra Nevada is building a huge brewery there.
oh, I didn't know.
Yeah, no,
Wow.
they're doing a huge thing. Yeah.
Wow.
Right. And we got here, let me turn this off.
Okay.
Okay.
All right. We're here to talk about outcomes as it relates to recovery goals.
Mm-hmm. Okay.
And you want to start by kind of telling us your thinking on it?
Sure. And feel free to talking about recovery as,
recovery goals is,
the whole recovery movement in mental health. Partly it's simply a matter of language. What do we mean? Tak and I we actually published an article fairly recently where we were looking at the whole issue of what's also called well-being. People say, well, we're not interested in measuring symptoms. We want to know about well-being.
we're not interested in pathology.
We're not interested in pathology. We want to see if, people are doing well, if they're thriving.
Right.
So we did a search of the literature for multiple different questionnaires that looked at happiness, well-being, thriving. One of them was really thriving.
Life satisfaction.
Life satisfaction. A number of different domains that people talk about as important. And we got a sample of items from these different questionnaires, and we administered it to a large sample of people who weren't in therapy, just a community sample. I forget how many we had, 500 or 600. And we did what's called a factor analysis. Are people familiar with the term factor analysis in measurement?
No. And I would say no.
What it refers to is when you're developing a questionnaire and you're trying to understand what it measures, you do what's called a factor analysis. And what you're looking at is which items correlate with each other. That would be a factor. And so you can tease out different factors. So, for example, if we look at substance abuse items, as opposed to items that measure depression and anxiety, we would see those are separate factors. They don't correlate that highly with each other. Well, when we looked at all these items for well-being, satisfaction, thriving, depression, anxiety, what we saw was that they were not separate factors. We had one factor. So, for example, if you ask a question, how often do you feel sad? versus how often do you feel happy, you're really measuring the same thing. We couldn't tease it out. It was what we call a single factor, which falls on the dimension of, you can call it well-being, you could call it distress. Basically, you have a single dimension of well-being, happiness on one end of the scale, distress, unhappiness on the other. But it was a single factor. And so we published that questionnaire, and it's being used some places. Well, recovery is a little bit like that. When we tried to identify items that measure recovery distinct from something else, we can't do it. So it's kind of in the eye of the beholder. So we have some questionnaires that have more positive items, positively worded items versus, items about symptoms. But from a measurement point of view, they're sort of opposite sides of the same coin, if you will. They're not really, they don't come out as a separate factor. Now, the other thing to look at is really when it comes down to it, the question is, how well does an item measure change over time in treatment? Because you want to use items that improve in treatment. So when we create a questionnaire, we also look at, we're not worried about questionnaires, we're worried about individual items. So we look at each individual item and we then say, okay, how much does that item change in treatment? And some items change more than others, and some items don't change very much. So for example, an item like, I have goals. We found that didn't change very much in treatment. That's one that you find on recovery questionnaires. So you have to be careful when you put together a questionnaire, and this is rarely done, I've found, because it takes a lot of data to do, to pick items that actually are sensitive to change. So, we can put together questionnaires that measure supposedly recovery. They're face valid. They look like they measure what they're supposed to. And the question is, how well does it work? Now, we're working with, in Oregon, a number of agencies, nonprofit agencies primarily, treating the Medicaid population. And they're required by the county to use some kind of a questionnaire. The county will let them use ACORN questionnaires, but they can use something else if they want to, but they still have to turn the data over to us. One of them said, well, we only want to measure recovery. And so there's a recovery questionnaire developed out of Denver, out of Colorado, that's gotten some traction. It's actually, you have to pay a lot of money to use it. I forget how many thousands of dollars they spent to get trained and used it. And we started looking at the results, and they were terrible. The patients weren't improving. Now, a couple things they did different was that they weren't measuring it every session, and they weren't giving feedback. So maybe that was it, because if you don't measure it every session and give feedback, you don't get as good of results. Maybe it was a problem with the questionnaire. When I looked and I tried to talk to the people in Denver who developed it, and I said, well, trying to find out, well, what kind of psychometrics did you do? What kind of normative data did you have? Did you evaluate these items? And it looked like they hadn't done that. They had made up items that looked good and looked like it measured, but they hadn't done the kind of psychometric work we would have done. So looking at this agency we were looking at, the results looked, pretty bad compared to other ACORN agencies. The question was, is it a problem with the questionnaire because it didn't measure change very well? Is it a problem with the services? It was hard to tell because we didn't have any good normative data from elsewhere. So as far as I can tell from having looked at these questionnaires, having done a lot of item analysis, recovery as what we'd call a construct, it isn't clear that it exists psychometrically. And I know this is going to get a little bit technical. if you will, when we talk about a construct, there are two kinds of constructs. One is a theoretical construct. Well, a real good example of a theoretical construct is depression versus anxiety. Okay, we want a questionnaire to measure depression, like the PHQ-9 or the Beck Depression Inventory. No, we want to measure anxiety, so we have the GAD-7 or the Beck Anxiety Inventory. Well, if you look at the items, they say, oh, well, that's obviously, this is measuring depression, this is measuring anxiety, this questionnaire says how often do you feel sad, this one says how often do you feel anxious. So those would be theoretical constructs. However, when we do a factor analysis to get at a true measurement construct, what is it really measuring? What we see is that there is not a factor for depression or a factor for anxiety. They correlate so highly with one another that for all intents and purposes, they're not separate. So something like the Beck Depression Inventory doesn't measure depression uniquely. The Beck Anxiety Inventory doesn't measure anxiety uniquely, and the two questionnaires correlate so highly with one another that they're really different aspects of the same thing. And as far as I can tell, with the concept of recovery, we have a similar thing. It's a theoretical construct, but we haven't been able to see it as a measurement construct. In other words, it doesn't, when we try to test the items, they don't show up as something different from what we're already measuring. It's just different sort of aspects of the same thing. Does that make sense?
Can we get back? I got to go back to that anxiety and the depression piece.
Mm-hmm.
So what you're saying is that the depression inventories don't necessarily just identify depression, but they identify issues in general that are going on with them?
Yeah, distress. And I'm happy if people want, and we've written a lot, but I'm happy to send you the articles. There was an article, it's a few years ago now, where they administered the Beck Depression Inventory and the Beck Anxiety Inventory to a bunch of patients at the same time. And they looked at it and they said, basically, these are not measuring anything distinct. They're measuring a global distress. They're just different aspects of the same thing. Tak and I have an article in press right now where we did a factor analysis on 63,000 administrations of the PHQ-9 for depression and the GAD-7 for anxiety. We gave it to the, had patients complete at the same time. We had 63,000, and we did a factor analysis. We could not find a factor for depression or a factor for anxiety. It was a single factor, global distress.
Okay, got it.
And measurement in mental health care is full of this. People are always making up new questionnaires for theoretical reasons. Well, we don't want to measure unhappiness. We want to measure happiness. Or we want to measure, what have you, thrive in life satisfaction. And yet when we test them and we look at it, they're not really different. They're just different aspects of the same underlying, what we call a measurement construct, the same underlying factor.
Okay.
Counterintuitive, isn't it?
What?
It's counterintuitive. If I were a clinician, I'd be like, I can't believe what I'm hearing. And I would have felt the same way if I was practicing.
Well, we have this with children, for example. We've had some sites and clinicians that are very opinionated. We want to measure strengths, not symptoms. We want strength-based. So we want items that measure strength rather than symptoms. And so we've done that. And again, we see the same thing as well. They still are measuring the same thing. They're different aspects of the same underlying dimension. Whether I ask you how often do you feel happy or how often do you feel sad, they're really kind of the same thing. How often do you feel like you have friends versus how often do you feel lonely? They're just different aspects of the same thing. So either work. And we can tailor the questionnaires to do that. But let's not fool ourselves that we're measuring something different. We're measuring the same dimension on a continuum of distress to well-being. Hope for the future. Now there's a good recovery. How often do you feel hopeful for the future, or how often do you feel hopeless? Again, it's just different ways of asking the same thing.
This is Ashley. I'm from United Way.
Hey, Ashley, how are you?
Hi. What we were originally looking at is recovery in the aspect of, we were looking at the recovery assessment scale. Mm-hmm. And so absolutely I understand where you're coming from, because it was divided up into several subscales. And I think they had a hopelessness or hope. Where put it?
She's looking for it.
Is this the recovery scale out of Denver, or which one is?
No, I think this one was out of Illinois.
Is what?
Out of Illinois.
Out of Illinois, okay.
I think of mid-90s.
Okay.
Developed.
So it's a very old one.
Yes.
Yeah.
So it had personal confidence and hope. These were the subscales. Willingness to ask for help.
Right.
Goals and success orientation, reliance on others, and not dominated by symptoms.
Right.
And so I went through and actually went back to the original papers and stuff and read through all the psychometrics they did on it. Mm-hmm. And I guess what we were kind of, when we looked at it and when I looked at what the group here showed me was an ACORN, we definitely saw similarities.
Yes.
To the different constructs, because as you said, recovery it's just a term made up of different sub areas, obviously.
Yeah. Exactly.
So I guess when we went through the recovery assessment scale, there were some items that were a little bit more focused on the hope and the strength. Mm-hmm. That were not included in the ACORN.
Right.
I don't know if you could talk to that, or if we could include something like that. I don't know if that's everybody. I thought that was kind of where we ended off on.
Well, Jen, before you answer that, my name is Lois. I'm from Family Services, and we actually need to get going with ACORN. So I'll just put that out there.
Hey, Lois. Well, those are excellent questions. Partly, and we look at what we're measuring. Often from the employer's point of view, which is often funding this through their insurance, or an insurance company's point of view, they're interested in reduction in symptoms. They want to know, did you reduce symptoms of depression and anxiety? Not did you make people happier. Now, from a measurement point of view, that's really the same thing. So it's a matter of what we call face validity. Does it look like it measures what you want to measure? So the reason that so many of the questionnaires have items that are based on reduction of symptoms is that's what the market asks for. But we could turn right around and measure it just the other way around. This article we published on what we called a well-being questionnaire was a perfect 50-50 mix of items that were positive and negative. It was a 20-item questionnaire. I think it was 20 items.
I remember that.
I think it was 20 items. Half of them were worded very positively. So you could call it well-being, you could call it recovery, you could call it, happiness. Half of them were worded negatively. They were about problems. And yet, when we did the factor analysis, it was all one factor. So I laughed. I called it the perfect Rorschach test. You could look at this questionnaire and you could decide what you wanted to call it. You could call it well-being. You could call it distress. It was in the eye of the beholder. But it was a perfect 50-50 match of items, mix of items. So I think it's a little bit about, face validity, what do we want to call it? Now, we can modify items. We have an item pool right now of about 300 adult items. Some of them we have more data on than others. Some are positive, some are negative, obviously. We can add more items. We have to be careful about creating just questionnaires right brand new. What we try to do when we're testing new items is to add items on a questionnaire where we have items we already have a lot of information on, so that we can see how the new item behaves and, basically does it improve in therapy and so forth. And that's how we ended up with so many items, because people are testing new items all the time. And we're testing new items. But you have to be kind of careful now. I worked with one site, and this goes back a few years. We won't do this anymore, where they wanted to make up an entirely new questionnaire, all their own. And a lot of it was they were just changing the wording of stuff, but they really had to have something new. And the problem was we did it, and then their outcomes looked terrible. Was it a problem with the questionnaire, or was it a problem with their services? It was impossible to tell because they made up a questionnaire. And we didn't have any normative data. So we avoid doing that anymore. But we can certainly create questionnaires that are more face valid for recovery or well-being, and that have, positive items. Again, we want to be careful how we do it. We can easily do that. Part of the problem we have right now is the funding issue. We don't have funding from Simpatico to create a lot of new questionnaires. We just don't have the funding. And again, all of that gets, it's just a matter of time. It costs to do that. We can move forward doing that, but we'd have to figure out where the funding comes from to move beyond the set of items that we already have a lot of data on.
So if I'm hearing you correctly, if we are careful and select strong measurement constructs with questions that you have already normed as reliable,
Mm-hmm.
the language we use around reporting back the results of those constructs doesn't matter. It would be equally valid for us to use recovery strength-based language and hopeful language as it would be for us to use hopeless negative language.
Exactly.
You mentioned
At the moment, we score all the questionnaires so that high scores indicate higher levels of distress. So if we have a positive item, let's say we have an item, how often do you feel happy? Well, we would score, if they said a lot of the time, we'd score that as a 0. If they said none of the time, we'd score that as a 4. If the item says how often do you feel sad, and they say none of the time, we'd score that as a 0. And they say a lot of the time, we'd score that as a 4. So we could easily turn questionnaires around and say, well, high scores are good. And now we're measuring well-being, versus high scores are bad, now we're measuring distress. But it's all just what we call it. From a measurement point of view, it really doesn't matter.
I have a question, just what you said, Jeb, about insurance companies, how they're interested primarily in kind of decrease in symptoms.
Mm-hmm.
From a United Way perspective, we don't have any restrictions as far as what we want to measure.
Mm-hmm.
We're more interested in what the research says are the important factors. So does that make a difference as to what would be included if we would add anything into ACORN, or is there anything different about what you have now?
One of the things that I would personally want to be very careful about the so-called positive items is that it's kind of easy to get to a ceiling effect. Because when we think about our own lives, for example, we're never like always ecstatic. So in some sense, it's going to be really hard to max out on that item. And we're less sensitive to higher levels of happiness compared to higher levels of sadness. And so there's a restriction of range that happens psychometrically speaking. And so from that standpoint, even though they correlate highly, factor analysis, it becomes a same, it's an identical factor, and I'm totally with that. On the other hand, if you want to create a measurement that's sensitive, we want to be, that's part of the reasons why we want to be very careful also about positively worded items, because we sometimes see that restriction. And so the items that we will be choosing, and if you so choose to have a lot of positive items, we want to make sure that the questionnaire as a whole, including that item and other items, have a good enough range of responses that we could capture change. So that would be the only caveat. Otherwise, whether it's worded positively, negatively, I think, as long as we test the items, and of course, I want to be careful about what I say because I want to test every questionnaire empirically. But from a construct standpoint, we shouldn't have an issue.
Yeah. You have to be careful. You really have to test every item because the items are different, Some show more change than others. And when we evaluate an item, we're looking at how well it changes over time in treatment. Now, questionnaires that were developed in the last century, I mean, measurement methodology has improved over time. 10 years ago, 20 years ago, when people developed questionnaires, I don't think they ever looked at how well did the item change over time. I don't know of any questionnaire developed in the last century where that was the case.
Actually, historically, it's been the other way around. Like, how stable are the items? So the initial development measurement started with personality, and so they were trying to measure something that's stable because they believed back then that people don't change, or there's some core things about them, about people, that stays constant. And of course, now we know that that's not the case. Of course, life situation, contexts, of course, treatment, you're expected to see change. And so it's been more of a recent development that we try to capture change as sensitive as possible, which becomes, in some sense, a harder construct to, or a higher, more difficult goal to achieve.
Yeah. I think the first questionnaire I know where we looked at, and anybody looked at evaluating change over time was with the OQ30, when we revised the OQ45 to go to a shorter version with just 30 items, and we did it with the youth version too. We evaluated items that changed. And so we kept the items that were most sensitive to change in therapy. Now, we published that in, when did the OQ30, the LSQ, that would have been
somewhere in the 80s.
No, not the 30 item. We did it for Pacific here.
Oh, yeah,
that would have been
90,
around.
What was it?
Well, 90.
Oh, the article that we published with my
cousin? No, this goes back even before that. The manual for the LSQ was Life Status, the OQ30. I think that was probably around 2000 or so. That was the first article I know, the first questionnaire I know of that we used that methodology. And we've since begun to use it for all of the ACORN items. So it's a more sophisticated methodology where you're looking at sensitivity to change over time. And I can tell you, having looked at every item, is that it's possible to put together questionnaires that show a lot of improvement or very little improvement just on how you pick your items. What we try to do with an ACORN questionnaire is have a good balance of items that are sensitive to change over time.
Oh, yeah, because the other thing about what items to include, I forgot to say. For example, potential for self-harm, potential for, those are items that we need to include.
They need to include in their, yeah.
And they don't change that much compared to like suicidal ideations or harming others, and substance use too.
Yeah.
But those become required mostly out of like clinical implications. So we include.
And you're saying those don't change much over time?
Actually, well, they do if they're elevated. The problem with some items, like the self-harm item, very few people endorse it.
Right.
So if it's elevated, it does change over time. And we actually have looked at it also. 10% of patients, their suicidal ideation gets worse in therapy before they drop out. Roughly, I'd have to go back and look. So there's some items we include because, and this gets a little complicated, it also goes to the idea of, this comes out of item response theory, which is much more recent, again, in the last 10 or 15 years, where you look at items that are sensitive for people with more severe symptoms, for example. So an item like, I feel sad, is a very good item for people in general. I mean, a lot of people will say, I feel sad sometimes. If you ask them, how often do you feel hopeless? Or how often you have thoughts of harming yourself, it's a much smaller percentage. So in general, it's not a great item, except that people who are very symptomatic will endorse that item. So it's an item that is really geared towards people that are much more symptomatic. And so again, when we create a questionnaire, we try to have the right mix depending on the population it's intended for. So for example, if we have questionnaires for severely mentally ill, we're going to have items on it that we wouldn't normally use. Items about hearing voices or, paranoid ideation. Those are great items if you're treating people with schizophrenia. But if you use them in a regular outpatient population, the percentage of people for which it's appropriate is so small that it's kind of a wasted item. So what we're trying to do is tailor the questionnaires to the population we're treating. And again, that's a much more sophisticated approach to measurement than what's historically been used. And it's made possible by the advances in both computer technology and statistical methodology. I mean, we didn't have the software to do this 15 years ago. And certainly we didn't have the capability to collect the quantities of data we collect the way we do now.
Other questions, guys?
I guess, what do we do going forward? Is the group, would we change? I don't know what the group's thought about that is. Change anything, or as far as anything in Acorn, add new questions?
I mean, one option, I'd be very interested if there was interest in developing more items and more questionnaires geared towards recovery, if we could find enough sites that wanted to use it and if we could get funded for it. It'd be great to do. Now, the other thing, to be careful about is evaluating a questionnaire on just one site. Because at the end, you don't know, was the results of that questionnaire based on that one site? I go back to the example from Oregon where we have one site with terrible outcomes on a recovery questionnaire. Well, is that a problem with that site or is it a problem with the questionnaire? We don't know. If we had 5 or 10 sites using the same questionnaire, then we can answer that question.
Mm-hmm. Yeah.
So if we had in your area, let's say with United Way, 5 or 6 agencies that wanted to explore a recovery questionnaire, and we could take the items we already have, maybe add some more. We would test it. We would need, hundreds of cases from multiple sites. We could very easily then begin to evaluate that and probably refine the questionnaire.
That's definitely a possibility. We've already discussed.
Yeah. It wouldn't be terribly expensive. If we had a bigger budget right now with Simpatico, we could do it, but the problem is that the budget is totally maxed out, just collecting all the data we're collecting now. And we just don't have, we're not a large enough organization to self-fund this kind of thing.
Sure.
Partly because, we keep our costs down in order to make it available.
Yeah, that's true.
But
Yeah, that's very true.
and talks laughing. I've had to learn to not be quite so quick to say, oh yes, interesting project, we'll do that, because we don't have the money for it.
Mhm.
Joel, I have a question. This is Celia from Catholic Charities.
Hey Susan,
Hi.
how are you?
Hi. My question is in relation to the 3 or 4 questions that you have on the ACORN currently regarding God or a higher power. Would you say that those questions are pretty much hope related?
I'm glad you asked that, and we're using that questionnaire in sites that have more of a religious orientation. And it's a very interesting question because it goes to the idea of what are we measuring. The issue came up, if you'll indulge me, I'll give you a little history on it. Talk and I were sitting around one day talking about, I wonder what role spirituality and religion plays in psychotherapy outcomes. Interesting question. We didn't know. It'd be fun to measure that. So we did a lit search, who's done work on this? And we found a very interesting questionnaire called the Brief Religious Coping Questionnaire, developed by Ken Pargaman at Bowling Green University. So I called up Ken, let's talk about this. I looked at the publications, and they were very, very good. 90% of the questionnaires I ever evaluate, I go, well, that was just sloppy work. Somebody made up yet another questionnaire, and sure enough, they collected some data and they published an article and they think they got something great. But Ken did something very sophisticated. He looked at items that were positive religious coping and negative coping. Positive coping would be something like, I feel loved and supported by God. Negative would be an item that I wonder why God is punishing me. I don't remember the exact items, but you get the idea, negative and positive. And he did a factor analysis. And what he found out was that, in fact, those were 2 separate factors. They really were 2 different things. Negative and positive religious coping weren't flip sides of the same thing. They were really 2 different things. The other thing he found was that the positive items did not correlate at all with anxiety and depression. In other words, it didn't matter whether you felt God liked you or not, it didn't correlate. The negative items correlated strongly. If you feel punished by God, you're likely to be depressed and anxious also. So we then said, well, that's interesting. So we then took, and I got permission, we took his 14 items and we took a number of our ACORN items and we administered it to, I think, about 800 people, a lot of people. And again, we did a factor analysis to confirm what Ken had already found, which was the positive items for religious coping did not correlate with depression and anxiety at all. They didn't, it was nice, but it had nothing to do with depression and anxiety. The negative items correlated pretty highly. And in fact, if I were to do a factor analysis, I would say they're the same factor as our global distress factor is. So we said, okay, we'll take the 2 best items and add them to the questionnaire, sort of as a study, as an experiment, to see what happens. And sure enough, we saw that if those items improve in therapy, other things improve too. They correlate very highly. If they don't improve, we don't get improvement elsewhere either. If they get worse, we tend to get increases in other symptoms also. So they're very useful items if you're treating a population of people who are faith-based. So and we're working on an article. Actually, we have a call. We're trying to schedule a call a little later today or tomorrow with a graduate student who's doing a thesis on this. We now have data for several thousand cases from multiple sites where we're then looking at changes in these religious items versus symptoms of depression and anxiety and so forth. But it's, and it's counterintuitive. You would have thought that these positive items would be great, you would think that feeling loved by God would be correlated with happiness. Turns out not so much. But if you think God is punishing you, you're probably depressed.
Mhm. So if we've been using the questionnaire that does not include the faith-based questions,
Mhm.
and then start using the questionnaire that does, how will that affect our data?
It won't.
Because we're going to collect our data at the end of the year to see,
Yeah.
you know.
It's not going to change anything because the math we're using behind the scenes, and I'll spare you the details unless you really want to get into it, is designed to, as much as possible, remove differences between questionnaires.
Oh, okay.
So it's sort of like, well, what is it, like SATs, these standardized tests, they have multiple versions, right?
Right.
But they, come up with standardized scores because they know how to equate the items. It's sort of like that.
Right. I mean, that's a good example. The SATs use different items every year. It's not the same questionnaire from one year to the next. And yet nobody questions the scores because they're using very sophisticated psychometrics to equate it. And that's something similar to what we're doing with Acorn. One of the problems we have, though, is that, this is the kind of measurement and math that has only really been possible in the last,
10, 15.
10 or 15 years.
Yeah,
And there are a lot of questionnaires that were developed back in the day that people still use.
right.
So it's a very sophisticated approach to measurement.
Right. I mean, of course, SAT's been doing that for longer years, but that's because they had the money and the computer technology that was beyond the highest end that we could ever get. And they had they had the resources to do it. But it's only been recent that you could do it on a desktop computer. I mean,
Yeah.
It's not something that was possible, until recently.
Yeah. Yeah, quite literally, some of the software wasn't available until recently to do the kinds of calculations. And a lot of what we're doing with Acorn right now would not have been possible 15 years ago, 10 years ago even.
So if we choose to use a different language and we have the money to do that so that you could help us with that, would, kind of piggybacks to this question that Celia asked, would it then, our outcomes starting whenever we'd start using it, you tweak it so that it wouldn't,
Mm-hmm.
I don't know, wouldn't affect our current, how it,
Right.
okay.
Yeah, no, what we want to be careful about is that the outcomes are not a function of the questionnaire itself. We want to be sure that the different versions of the questionnaires are going to produce similar results.
Right.
Back to the analogy of the SAT, you don't want SAT scores from one year to give you different results when you do it another year. You have to be very careful how you design it. And that's what we're trying to do. And we're using, again, I'll spare you the details, but how we do the math. And we publish papers on this. I'm happy to share them. Though they get so technical that my experience is when I share them, nobody reads them because unless
Well, if you're interested, please.
it just,
most people aren't really interested.
None of us are that interested. Thank you very much.
Yeah.
No, we're good. We'll trust you.
Yeah. But we try to create questionnaires and then score them in such a way that you're not going to get better results with one questionnaire than another. I can give you more examples. I tell you, for example, we look at trauma. We had some sites that were, they're saying, well, a lot of our people are survivors of trauma. We need a trauma questionnaire. So we added items that were very face valid for survivors of trauma and PTSD. Well, what we found is, once again, that was not a separate factor. And those items behave very, very similarly.
But was it a mitigating factor at all in terms of how long it might have taken someone to get well, for lack of a better word?
Actually not. Well, yes and no. Let me explain that. And this goes back a few years, but that was one of the pushbacks we got. Well, we see patients with a history of a lot of trauma. So, you can't expect us to have the same results. So we said, that's an interesting question. Let's find out. So we administered a questionnaire called the ACE. It's the Adverse Childhood Events Scale. It was about 8 items that ask about childhood trauma, basically bad things happened to you as a kid. And we administered that along with her outcome questionnaire. Well, what we saw was, sure enough, first of all, the percentage of mental health patients who don't have something bad happening as a kid is pretty small. Okay, so there's that. What we saw was that, yes, you're right. At intake, people with a lot of trauma have higher symptoms. Okay, that wasn't a surprise. But the question is, do they show more improvement or less improvement? And that's where we found no difference. Patients with more symptoms also tend to show more improvement in treatment. And so paradoxically, we found the more trauma they had, the more improvement they had, but that's because they were more symptomatic at intake. Once we controlled for that, we saw that the amount of childhood trauma seemed to make no difference at all in the treatment outcome.
And no difference in how long it took for symptoms to be reduced. Okay.
No. If anything, no, it didn't seem to make any difference. But part of the problem was that a very high percentage of people in mental health treatment have adverse childhood events. The percentage of patients who didn't have any was pretty small. We also saw, though, that it didn't seem to matter how many you had. And we drilled down, is one item worse than some kind of experience worse than another. We just couldn't find it. Now, it might be there. Maybe a lot more data would have showed it, but we couldn't find it. Similarly, we hear this all the time, that some diagnoses are, much more, don't have as good outcome as others. And yet, when we start looking at that and collecting diagnostic information, we don't really see that. They do have very similar outcomes. They may have different levels of symptoms at intake. So, for example, somebody diagnosed with depression is going to have a higher score on global distress than somebody diagnosed with adjustment disorder. But once we control for the differences in the number of symptoms at intake, we can't find much difference in the outcome at all.
Well, one population that is different is the severe and persistent mental illness.
So we started looking at schizophrenia. Yeah, that's different. There's some that are different. Substance abusers get a lot, people with substance abuse diagnosis get a lot of improvement on symptoms of depression and anxiety when they stop using. So they look different. They get a lot of improvement compared to people diagnosed with depression and what have you. But what we've learned is that, over time, what we've seen is that often what people believe to be the case, when we start measuring it and testing it, is often not the case. The other thing we run into is that there is so much variability in the outcome based on who the therapist is or where the site is. That's far more important than the diagnosis. I mean, if I had to predict an outcome, what I would say is, tell me who the therapist is. Don't tell me the diagnosis. Don't tell me what kind of treatment they did. Just tell me who the therapist is. And that will give me a much better prediction of the outcome than knowing what the diagnosis was or what the treatment method was. Because there's so much difference across therapists. The top 25% of the therapists get about twice as much improvement per case as the bottom 25%. And that's what you'll find again and again. It's all about who the therapist is, what's the quality of the relationship. It's not about what treatment they said they were doing or even much what the diagnosis is. It's about the quality of that interaction between that therapist and that patient. That's where the action is, which is why ACORN has been successful in improving outcomes, because it's focused on helping therapists do their job better. It's not focused on saying we'll do this treatment or that treatment. And what we see is that, okay, the therapists were already getting great results. Let's say that 25% of your top performers, ACORN probably isn't going to improve their results that much. But if you look at that 25% of your bottom performers, odds are their results improve quite a bit with ACORN if they're looking at their data and getting feedback. If they don't look at their data, they don't get much improvement at the therapist level. Psychotherapy is a skilled activity. And with any skilled activity, if you want to get better, you got to have performance feedback. And unfortunately, in mental health care, we have a history of not giving any kind of measurement performance feedback to therapists. And as a result, they don't get better over time. At this point, I think the research is very, very clear, is that therapists don't naturally get better with experience. Experienced therapists do not get better results than graduate students. We probably get about as good as we're going to get by the time, I know Scott Miller in his work, he estimates after 50 hours of experience, we're as good as we're going to get, unless we're getting continuous performance feedback. And we can certainly see that in our data. Tak was a lead author recently on an article that looked at results from a large training center at a university, where he compared results from the graduate students compared to the experienced full-time professional staff. The graduate students had an effect size of 1, and the full-time professional staff had an effect size of 0.55. The students were getting almost twice as much improvement as their, elders, if you will.
Yeah, don't quote us on the exact numbers because I'm not precisely recalling, but basically.
It's pretty close.
Well, exactly.
Yeah.
It was actually shocking for me as well to see, because I still had back then the belief that, practice and experience should really matter. And in fact, it's kind of, it's really shocking that it's not at all.
Brigham Young University in their training center, they published the same thing, found exactly the same results. Bruce Wampold and I did a very large analysis at University of Wisconsin. We published this where we looked at therapists in the real world. We had a lot of data, thousands of therapists across the country, and we were able to look at how many years of training, what kind of degree that they have, and how many years of experience that they have. And we saw absolutely no correlation at all between training and years of experience and what their outcome was. So what we see now is that therapists don't naturally get better over time with experience in the absence of measurement and feedback. They become more confident over time. So if you ask a therapist with 20 years experience, they will tell you that their outcomes are better than a new therapist will. They have a lot more confidence. But we have no evidence that that's really the case. The only thing we've ever seen that has actually improved therapist outcomes is the measurement and feedback. Similarly, we've not been able to identify that there is one treatment method that is superior to another. Now, there may be some caveats around the edges, but broadly speaking, we have no evidence that cognitive therapy for depression produces better outcomes than some other therapy for depression. None at all. Actually, we have a lot of evidence that that is not true, that the results are pretty much the same. A book I would highly recommend if you're really interested in looking at this is the second edition of The Great Psychotherapy Debate by Bruce Wampold and Zach Imel. It just came out in February of this year. It's a very good up-to-date review of the literature. And sort of, parenthetically, Zach Imel is at the University of Utah now, and we're putting ACORN in place with their training clinic at the University of Utah, so that their graduate students come out, one, knowing how to measure their own outcomes, and secondly, with some idea of what their outcomes are. We have an article coming out now, that addresses this, the business of training graduate students without ever measuring their outcomes, I think really is a disservice to the students. this goes back a couple of years, but I was a consultant to, there was a graduate program that wanted to use Acorn. And I said, fine, in fact, this is back when I would do this. Well, you can use it for free because I was interested too. I don't do that anymore because it's too expensive, but I did it. And the professor said, well, but I don't want the students to be able to see their results. I just want you to share with me. And I said, well, why would you do that? The whole point is to give the students feedback. And you know what he said to me? He said, these students are paying $60,000 for a degree. It might be a problem if they saw their outcomes were bad. Talk is the chair of a graduate training program for counseling psychology. That's why he's laughing. That's exactly the kind of attitude we would like to get away from.
Right.
Absolutely.
Yeah.
That particular guy, I just said, this is what I think. I tried to be as nice as I could. I said, this is exactly what is wrong with our profession. If these were dental hygienists, you would make sure they knew how to clean teeth before you graduated them. But we're perfectly willing to graduate therapists with no idea what their results are.
Yeah.
And then pat them on the head for doing a good job.
This is sort of a related subject because it reminded me of a question we had the other day with one of our staff. They were asked, they wanted a client because of some self-harm concerns, a therapist was seeing them more than once a week. Mm-hmm. And she wanted the Acorn administered every time they came in. Mm-hmm. So it would be more than once a week. I checked some information that we received from you that says it should not be administered more than once a week. Are you still saying?
Yeah, well, I know where you got that from, but I would say, first of all, let's use a little bit of common sense here. The recommendation for once a week came out of, there's some sites that are intensive outpatient programs where they're seeing patients 3 or 4 times a week.
Okay.
And we're saying, well, in that case, why don't you just do it once a week? Okay. But if you're in regular outpatient care, sometimes you increase the frequency. I want to know the suicidal ideation. I'm on vacation right now. I have a young man I saw, and the last time I saw him, his suicidal ideation had jumped way up. And I encouraged him to complete the questionnaires because he could do it electronically and I would see the results. I said, let me know how you're doing. Complete the questionnaires while I'm away and let me know how you're doing. And, I got an email from him and his suicide ideation had dropped. He said, gee, I'm dealing with this. We exchanged a couple of emails. Yeah, no, if I were seeing somebody who I thought was at risk, I would want to be measuring them every time and I'd want to track suicidal ideation.
Okay.
And his suicidal ideation had fallen way down again. He was doing much better. And he actually, I think he said, eventually he sent an email. He says, I'm discovering that when I do a better job of managing my anxiety, underneath that there's a lot of anger. And I'm going, yes, okay, now we're getting somewhere. Let's talk about the anger, not the anxiety,
Sure. So you're okay, and she was going to administer it. She just wasn't going to submit it to Acorn.
Yeah, no, just.
So you're okay with it being submitted as well?
Yeah.
Okay. All right, thanks.
And, I've been experimenting in my own practice, having clients, do it more often and just let me know how you're doing. And some of them seem to like that.
Okay.
And so I see it as kind of a therapeutic intervention. Yeah, let me know how you're doing. I'm interested.
Right. Okay.
Yeah.
All right. I think we need to wrap it up. We've got to get going. But thanks a lot for your information. And if we will be interested in developing a different form with other agencies and have some funding for that, we will get back to you on that.
Yeah, okay? I would be very interested in working on that. That'd be great.
All right.
But I'd be willing to bet any amount of money that we're going to find that recovery items, are like other items.
Kind of interesting to find out.
Yeah.
All right. Thanks a lot for your help, and we'll be in touch, okay?
Great. Thanks.
Thank you very much.
Bye-bye.
Bye. Bye.
Okay.
You have to stop the recording first.